So good morning. My name is Nicki Chopski, and I am the Executive Officer of the Boards of Medicine, Nursing, and Pharmacy. I work at the Idaho Division of Occupational and Professional Licenses as the Health Professions Bureau Chief. I'm happy to be here today to talk to you all about optimizing the use of the prescription drug monitoring program, as this is a key tool that we have in our belt to help us address the opioid epidemic that occurs in Idaho. So I have no disclosures to report today. I have no conflicts of interest. And my only disclaimer is that while we will be covering changes that occurred in the law in the last year or two that affect the Pdmp, my presentation today is not a substitution for reading the law in its entirety. I have 4 objectives to review today. The first one is to identify recent statutory changes that impact the Idaho Prescription Drug Monitoring Program, to describe requirements of mandatory checking of the Prescription Drug Monitoring Program, to explain Gateway and its benefits, and to summarize 3 types of reports that are generated through the Prescription Drug Monitoring Program. This slide shows the why behind what we're doing with the Pdmp. As you know, or probably are aware, Idaho overdose deaths have continued to increase over the years. And it certainly did not get better during the pandemic. So on this slide, I realize the colors are light and the print is small, but what you're really looking for here is some general overall trends on this slide. And you can see that the numbers have continued to increase from 1999 going to 2019, which is the last date that we had Idaho overdose death statistics. And you can see as we go to the next slide, that the main cause of overdose in Idaho continues to be a combination of both prescription drugs as well as illicit drugs involved. And the number of deaths we had in 2019 were 265. This list does go on to describe other types of overdose deaths that we've seen in Idaho, but clearly the big factor here that we need to address is the combination of prescription drugs and illicit drugs. So there's 4 points of the Idaho Pdmp that I want to talk about today. The Pdmp stands for Prescription Drug Monitoring Program, and I will likely use the acronym interchangeably with the full name of the program. But the 4 topics that we'll talk about are enrollment, access, use, as well as administration. Before we start with the enrollment, we'll talk about what is the Pdmp, and what is the history of the Pdmp in Idaho. So our prescription drug monitoring program was established in 1997, and it is a database of all Schedule 2 through 5 controlled substances that are dispensed in the state of Idaho or mailed into the state of Idaho. The only exception to these controlled substances is naloxone. We also capture naloxone data in our prescription drug monitoring program. And our legislative authority to have this database comes from Idaho Code 372726, which states 2 things. First, that all controlled substances and opioid antagonists dispensed for humans should be filed with our division, and that the division shall create, operate, and maintain a controlled substance prescription database containing this information. And as to the why we do this, well, 1, I mentioned already that opioid deaths from opioids continue to be on the rise and certainly did not get better during COVID. So our purpose is actually stated right in the bill or right in the statute, and it says that our purpose is to identify illegal activity related to the dispensing of controlled substances and to assist the division in providing information to patients, practitioners, and pharmacists to assist in avoiding inappropriate use of controlled substances. And the code references as I go through these slides will be in the lower right-hand corner of the slides, and other references will be at the end of the slides if not cited on the slide. We do also have a few rules. So of course, the legislature sets out in statute our authority to have a Pdmp, and then the board sets out in rule just a few additional details to help maintain and manage the database. So in Idaho Rule 243601, Rule 600, it says that each dispenser must report their data by the end of the next business day. And that means that the data within the Pdmp should be current to within 24 hours of when the information hits the database. So it's not instant real-time data, but it is pretty close to that. The rule goes on to say, and this is where we talk about enrollment into the Pdmp and access, that first of all, enrollment is mandatory. Every prescriber and every dispenser in Idaho, in order to obtain a controlled substance registration, must be registered with the Pdmp. And so enrollment is mandatory, but it is also free, and it takes about 1 minute to do. The online access to the Pdmp is given to those who are prescribing and dispensing. We also do give access to other folks like law enforcement, prosecutors, attorneys, those kinds of things. Those are not done online. Those are done through a request with a case number, and the board does process those requests to the tune of about 1,200 of those requests a year. But for those that have online access, which is the majority of our folks, prescribers and dispensers, all they need to do is complete and submit a registration application and agree to adhere to the access restrictions that are established in the law. So 600.02 goes on to speak in more detail that the use of the data in the Pdmp cannot be outside of the scope of practice. More specifically, the data information should be used only for a prescriber to decide whether to prescribe and for a dispenser to decide whether to dispense a prescription. It should not be used to obtain information outside of that scope. And a few examples that we've seen and that we've heard about are looking up your family members or your extended family members, checking on a boyfriend, girlfriend, or a former spouse, checking on your adult children, or an employer searching an employee or a potential employee. And on this slide, I do have a few pictures of some famous people because there have been some instances where this has been taken too far, I would say. Michael Jackson, when he passed away, there were multiple attempts at both the California and the Nevada prescription drug monitoring programs to try to figure out what drugs not only was Michael Jackson on, but what drugs his physician was on. Those are inappropriate fishing expeditions, and they were handled as such by those states. When Prince passed away, the Minnesota Pdmp had a spike in requests for searches looking for information on what Prince was taking, what medications he was on. And lastly, the top picture there is Stephen Paddock. He was the active shooter in the Las Vegas Mandalay Bay concert. And in his case, a pharmacist actually lost their license because not only did they search the Pdmp inappropriately, but they then sold that information to a third-party media outlet who published that data. And through IP addresses, the investigation led to a pharmacist being prosecuted for inappropriate use of the Pdmp. So I put that out there as a reminder. Usually what we see are not such famous celebrity cases, but nonetheless, whether you're a celebrity or a private citizen, your data should be protected. And dispensers and prescribers should not be using that data for anything outside of their scope of practice. The Idaho Code from the legislature takes this one step further and fairly seriously. Anyone who is intentionally sharing or recklessly fails to protect their username or password can actually be convicted of a crime. It's a misdemeanor, punishable by both a fine and some imprisonment, which is unusual because this is generally administrative code that we're talking about. But in this situation, there is a criminal process involved for those who are engaged in inappropriate activity. So that's enrollment and access. Next, I want to talk about a little bit of use and action, and that ties right into what statutory changes have happened in the last year or two that would impact the Idaho Prescription Drug Monitoring Program. So the first statute update I want to provide today is through the legislative session of 2021, and it changed the number of delegates that a prescriber or dispenser could have. And so all of these changes that you're going to see are made to make the process more convenient and less burdensome, so that in hopes of encouraging folks to use it. So this one, we used to have a rule or a statute that limited prescribers and dispensers to having 4 delegates. That limitation of 4 has been removed, and now a prescriber or dispenser can actually have unlimited delegates. And delegates, in turn, can be a delegate for more than one prescriber or dispenser. And so that should help free it up. We do recommend that the delegate list be reviewed by the prescriber or the dispenser at an annual basis. And we have printed in our newsletter the process by how to do that, or you can certainly contact our staff here at the division to walk you through that. But to make sure that you don't have any former employees who still have access or who would be accessing the Pdmp under a provider, prescriber, or dispenser that no longer wishes them to have that access. The next statutory update that also impacted the Pdmp was the enhancement of 541733B, which is our naloxone statute. It says that notwithstanding any other provision of law, if you are licensed or registered under Title 5417, which includes more than 16 health professions, you can prescribe and dispense naloxone. And this would come as a surprise to probably some of the professions that would be included. For example, social workers, occupational therapists, physical therapists, folks that speech therapists, people who don't generally prescribe or dispense. Technicians, pharmacy technicians would be included in this group. Frankly, RNs and LPNs would be included in this group. This makes it as broad as we can to try to make naloxone as widely accessible in Idaho as possible. We cannot make the talk was actually whether we would be able to make naloxone over the counter in Idaho. It is restricted to being a prescription drug product by the FDA, so we are not able to make it over the counter, but this was the legislature's way of saying we want it to be as widely available as possible. And so really anyone licensed or registered as a health professional in Idaho can prescribe as well as dispense. And that also leads to a conversation about, can I carry it on my person? Can I possess it? And can I administer it? And the answer to those questions is also yes. There are no restrictions in Idaho on who can carry naloxone nor who can administer it. And so you don't have to be a licensed healthcare professional. We see it with law enforcement. We see it with fire department. We see it at homes that are treatment homes or shelter homes that come across folks or come into contact with folks who may be in need of having this together with them as a safety mechanism. And so there are no restrictions on carrying or administering. And there are also Good Samaritan laws in place to help protect those who try to save another person's life with naloxone. And that leads me to our next slide, which is about naloxone co-prescribing. The AMA, the American Medical Association, has released updated guidance encouraging providers to co-prescribe naloxone with opioids. And there is some data out there that shows that the co-prescription of naloxone with an opioid does decrease in the risk of opioid overdose, even if the prescription for naloxone does not get filled. And so we do encourage and recommend that prescribers, particularly those that are prescribing at high MME levels, would consider co-prescribing naloxone. And we also put it on the pharmacists or the dispensers who are filling these prescriptions for opioids to consider offering naloxone to patients who might be of benefit or of use. And it doesn't have to be a patient. It could be a family member. It could be a friend. It can be anyone who is in a position to help someone who may be at risk of opioid overdose. Those folks can get access to naloxone. Next statute, this is not new, but I do want to talk just briefly about corresponding responsibility. I think most prescribers are probably aware that the DEA holds the proper prescribing and dispensing of controlled substances upon the prescribing practitioner. However, the pharmacist or dispenser has a corresponding responsibility to the DEA to make sure those prescriptions are of legitimate medical use and purpose. And I put on this slide, that's why pharmacists call. So I don't know how many of you are providers in the room, but if you are, find those calls from pharmacists to be bothersome, I would just encourage you to be patient with them as they fulfill their corresponding responsibility, the same responsibility that the DEA holds the prescribers to. And the reference to the CFR citation is there on that slide as well. So we talked a little bit about enrollment being free and being quick and being mandatory. We talked about who can access the Pdmp in general terms of prescribers and dispensers, as well as others in law enforcement and certain researchers by request. We've talked a little bit about the use of the data and why we use that data, but now I'd like to talk a little bit about actions you can take. So the first action that we would encourage folks to take is to consider red flags. Now, red flags are a loose group of points that you might want to consider when seeing a patient, but none of them on their own would be a reason to not prescribe or not to dispense. But when you look at the whole picture, you may see some cautionary reasons to think twice about prescribing. So some of those are patients that pay with cash, patients that travel a long distance. I will say on patients that travel a long distance, we don't have a lot of ex-waivered prescribers. And I know the federal government has recently removed some of the restrictions around the X waiver, making it so that if you just have a DEA and you're only seeing 30 patients or less, you don't actually have to have the X waiver. But we do know that providers are rare in Idaho. We rank 50th out of 50 states for providers per capita. So we know that some folks, in order to find specialty care, do have to travel a long ways. So just traveling a long distance does not necessarily create a red flag, but it certainly would be something you would want to look at. Evidence of doctor shopping or pharmacy shopping. This is something you would find when you actually look at a patient's profile in the Pdmp. Any patients that are pulling up are traveling in groups and pulling up to a clinic or a hospital ER or even a pharmacy to get certain scripts, either obtain them by prescribing or to fill them through dispensing could be a reason to raise a red flag. Patterns of early refills, of course, and then looking for that highly abused cocktail or highly misused cocktail of opioids, benzodiazepines, and muscle relaxants. There are others, but that slide certainly captures probably the major ones. And then there's a few new statutory requirements that also play into how this information is put to use or what actions are taken. So I'm next going to talk about the mandatory checking of our Pdmp. So in October of 2020, in the 2020 session, the legislature passed a piece of legislation that requires mandatory checking of the Pdmp. The legislation went into effect in July, but it had an implementation date of October 2020. And it applies to any individual that is required to register with the Pdmp. So again, that would be anyone who's dispensing or prescribing to a human is required to register. So what the rule says, it's 372722F. And what it says is that prior to issuing a prescription for a patient, an outpatient prescription for a benzodiazepine or an opioid, the prescriber must check the Pdmp for a 12-month period of the patient's profile to look for indicators of prescription drug diversion or misuse. And there are a few exceptions to that. So the exception list is here on this slide. It's prescriptions in a quantity that are intended to last no longer than 3 days. So if it's a 3-day supply or less, you are not required to check the Pdmp. If the patient is receiving the treatment in an inpatient setting, in other words, they're hospitalized, the Pdmp does not have to be reviewed. If you're at the scene of an emergency or in an ambulance, if you're in hospice care, or if you're in skilled nursing facility, the Pdmp does not have to be reviewed for those reasons. But all other outpatient prescribing, it does require a review each and every time an opioid or a benzodiazepine is prescribed. I will say that this was not this legislation came about as part of the governor's opioid task force that was put together. That task force included not only healthcare professionals, the Board of Medicine, the Board of Dentistry, the Board of Nursing, the Board of Pharmacy were all at the table. But it also included prosecutors, law enforcement, treatment experts, those in both in rehab and in recovery. and really a wide variety of folks were involved. Educators were involved. And this is legislation that came out of that group. It does end up falling within the Uniform Controlled Substances Act, which is applicable to all prescribers as well as all dispensers. And because that was housed at the Board of Pharmacy ended up sort of being the one tasked with maintaining it, but it really was not a Board of Pharmacy piece of legislation, nor was it any of the regulatory boards. They were all there at the table, but it was not generated by the boards themselves. On the next slide, we talk more about the Pdmp requirements for mandatory checking. First of all, a provider only needs to view the Pdmp one time per encounter, even if you're writing multiple prescriptions. If you have a delegate linked to you as a provider, they're checking the Pdmp will suffice for you checking the Pdmp, as long as they do provide you with the information that was obtained from the Pdmp when they did their check. The check can be done up to 5 days in advance. So if Monday mornings worked well, you could have a delegate run all of your patients for the week and have those Pdmp reports on their charts, and that would count for checking the Pdmp before that visit and before any prescribing. And it is important that there are no requirements for prescribers to document their Pdmp checks. The system actually has a way to check for compliance and monitor who is checking and who isn't checking. We're going to look at some data in just a few slides around that. But the Pdmp does have a compliance module. And to date, our enforcement has been educational only. It was pretty important to the committee, as this, not only did they allow for a couple of months period of implementation after the law went into effect, they also were clear that they wanted this to be educational in nature. And so the way that we've gone about enforcing this has been through presentations like these around the state and with health professional associations of the various health professions. So next slide. In 2020, we did do some tracking of how our Idaho prescribing and Pdmp checking was going, what the habits were. You can see on the chart below that we measured physician assistants, nurse practitioners, physicians, which included both the MDs and the DOs, and the dentists. Physicians by far prescribed the most, dentists by far prescribed the least, and then you can see their searches in the next column, the number of licensees in the next column, and then we did a little math and we figured out that prescriptions per provider, if you take into account how many providers there are and the number of scripts they wrote, while the dentists don't seem to check very often, they are a small piece of the pie. And it's fairly similar numbers between the PAs, the nurse practitioners, and the physicians as far as prescriptions per provider. If you look at the script check rate, which is there on the far right-hand column, you'll see that PAs nudged nurse practitioners out as being the better checkers at 29%, with the nurse practitioners coming in at 27.3%, and then our physician group right behind that at 19.5%. So this was in 2020. Of course, the rule went into effect in October of 2020, so we should be seeing those numbers increasing now. Here's some more recent data that captured both the end of December of 2020 and into the beginning part of first quarter of 2021. And you can see that for the most part, the numbers are increasing. Remember that the rule went into effect, or the statute went into effect in October. And so that's where you can kind of see spikes in each one of these lines is when the practitioners knew that the law was going to go into effect. We have seen it drop off a little bit in the spring of 2021, but our more recent data shows that things are, again, trending in the correct direction. This slide is really just a graphic to compare with the next slide. What I would want you to pick up on this is what we call 37, 27, 22 compliance. In other words, compliance with the actual law. And you can see in July of 2020, we had nearly 2/3 of providers, prescribers checking 0% of the time. That's that big blue section on the pie. And we had the smallest pieces of the pie are the 100% checkers and those that check 3/4 to 100% of the time, smallest pieces of the pie. Now, in comparison, this is 1 year later, July of 21, you can see that our 0% checkers are down to almost 50%, and our 100% compliance and our 75 to 99% compliance pieces of the pie are much larger. We clearly still have a lot of work to do. We're still out educating, but we have seen improvement in the mandatory checking that is required by law. Next, I'm going to spend a little time explaining what Gateway is and its benefits. The biggest thing we hear from providers is that I'm very busy. You know, we have a very packed patient schedule. I don't have time to check. So we've, again, tried to make things as easy and convenient as possible for checking. When the Pdmp was first developed in 1997, we had an in-house software system. As time grew in 2014, we ended up, our shelf life of our homegrown system essentially outgrew itself, and we ended up with an off-the-shelf product that we use now. That product in 2014 required that all providers go into a separate website, which would mean in pharmacies, it meant closing out your dispensing screens. In clinics and hospitals, it meant closing out your patient profile and accessing the internet and going through a website. Gateway, as you can see on the screen, through the Idaho Board of Pharmacy and a Bureau of Justice grant that we received, we're able to come up with the money to install Pdmp Gateway. And what that is basically an integration into your healthcare IT system, whether that be in a pharmacy, whether that be in a clinic, or whether that be in a hospital. So the patient request goes from the IT system out to Gateway, and then the response comes right back to the health IT system. What this does is it allows the system, the button, to be integrated into the software, making it unnecessary for you to close out a program. And so Gateway initially was available to folks who are most interested in it, but over time, the state saw our searches jump incredibly once we had Gateway. And so with that, the state legislature did provide funding so that the state will pay for the licensing fees to get providers into Gateway. So if you are not yet on an integrated system with Gateway, we do recommend that you reach out to the Pdmp providers here at our office, and we can help you get the information you need to get your EHR or your pharmacy software system engaged, and certainly make the process far more convenient for you. The other thing we have through Gateway is we have our interconnect, PMP interconnect. We do connect with 36 other states, Puerto Rico, and most recently the Military Health Service. So you can see Idaho there, surrounded by all of its neighbors. We exchange data with all of our neighbors, and then across the country. There are a few states left that we do not have agreements yet with, but we continue to work with those states to come to an agreement on what the terms would be to share that information. Most importantly, of course, is to have information shared with our neighbors, especially for those of you who live in cities that border other states. So as I was mentioning, this puts the button to access the Pdmp right into your EHR or your pharmacy IT software, making it far more convenient for you to access the Pdmp. Next, I'm going to talk about 3 different types of reports that are generated from the Pdmp. The first report I want to talk about is the Narc Care report. This is an analytic tool that assesses patient risk, and it comes with Gateway automatically. If you have Gateway, you automatically get this report or this tool. And basically what it does is, in a visual format, aggregates 2 years worth of prescription data. It shows the number of prescribers the patient's seen, the morphine milligram equivalents that they've used, any overlapping prescriptions that they have, and the number of pharmacies they shop at. Besides giving you that visual platform or visual information, it does give the patient a score from 0 to 999. You can think about this sort of like a credit score, with the high score meaning higher risk for the patient to have an adverse event related to their opioid use. It does check narcotics, sedatives, and stimulants. So it does give a fairly decent overall picture of what the patient's risk is. This is a picture of a Narc Care report. I realize that on the screen you can't actually read those details, but it does show you at the bottom on the left what the overdose risk score would be. And it does help people to make decisions, clinicians to make decisions on whether they do or don't want to prescribe and whether they do or don't want to dispense to this patient. And then you can see on the top right in color the graphics of when the prescriptions were dispensed and what they were overlapping with as they were dispensed. You can also tell the number of current active prescriptions by the last digit of the overdose risk score shown there at the bottom on the left. The next report I want to talk about is called Prescriber Report Cards. And this idea came up through a project with the Office of Drug Policy, which is a portion of the governor's office, and the Idaho Board of Pharmacy. So these are quarterly reports that go to prescribers. They are sent, it's an automated report. The Board of Pharmacy does not see the report or review the report. It's an automated reporting system that just sends the report out to the prescriber's Pdmp account. And what it tracks is patients that the prescriber has that are on more than one opioid, the top 3 drugs that the prescriber is prescribing, the duration of their opioid treatment, their total MME, any medications they were prescribed that are controlled. It does show the Pdmp usage in the terms of searches, and certainly those who are exceeding multiple provider thresholds, which is greater than 5 prescribers in a month. It does also show dangerous combinations, and probably the most helpful is the last bullet point here on the slide, which is a comparison of peers in like specialties. So when you are looking at these reports, they are telling you, compared to all the other pediatricians, this is how you compare to your peers, or compared to all the other orthopedic surgeons, this is how you compare with your peers. Certainly pain management is one that we, if you compare a pain management person to perhaps a pediatrician, the pain management person would look like they were totally off the charts. However, if that pain management same person is compared to a group of other folks who focus on pain management, they may be right where they need to be and not look like an outlier. So that is the point of these Pdmp quarterly reports. We do know that they work. We do get feedback from prescribers. If you see something on there that you don't think is related to your prescribing, you're certainly welcome to call the Board of Pharmacy. We have investigated those types of reports before to determine whether the data was accurate or whether there was some sort of mistake in the data. This is what a prescriber report, quarterly prescriber report looks like. It's also very visual. You can see there on the left, I know the writing is too small for you to see, but what those blocks are is the top one is opioids, the next one is buprenorphine, the third one is sedatives, and the last one is stimulants. And so it does show how the prescriber has been prescribing. It does talk about how many other prescribers are in your specialty, and it does give you your search data at the bottom. And then the third type of reports I want to talk about are the unsolicited reports. We do have legislative authority to provide these reports. What we do is we run a program that identifies patients that have controlled substances from 4 or more providers in 2 or more pharmacies. Basically, each practitioner or prescriber and each pharmacy or dispenser that service these patients are notified using their Aware Pdmp program, receiving a letter. The letter says, hey, we're not judging you, but we just wanted to let you know that your patient may not be being honest with you if they tell you that you're the only provider that they're seeing. I call this the cheater report. It rats out patients who are cheating on their providers and cheating on their dispensers and telling them that they're the only ones. We find this to be a very effective report. Rarely have providers shown up in consecutive months. So generally, once we send a report to let a provider or a dispenser know that their patient has been seeing other dispensers, that generally calls for a conversation. Sometimes it's warranted. There are times when folks need to see multiple providers, but there are other times when the provider thought that they were the only provider providing for this patient until they received an unsolicited report. That generally also prompts, before we had mandatory use, that was actually one of the biggest triggers for getting folks to start checking the Pdmp was when they received an unsolicited report. And my last slide here is just to show what the impact of our unsolicited reports program has had. Again, I know the colors are a little bit hard to discern, but the tall lines are the medical doctors or MDs. The red lines are the physician assistants, and the faint green is what the color that is, are the DOs. And what you should really be looking at is from left to right. This is 2015 to 2019. You can see that in each category, the numbers are dropping of how many letters we had to send out to providers and dispensers to let them know that their patients were seeing other providers and other dispensers. 2020, which is that far column on the right, looks like we've had a spike. It does look like a spike, but it's an artificial explainable spike in that the criteria that we used from 2015 to 2019 for those first 5 years was if you had had 5 opioid prescriptions and been to 1 pharmacy. In 2020, we changed that criteria from 5 down to 4, and that's what's resulted in the increase in letters that are going out to folks. And then I'm happy to stand for whatever questions you might have for me. Thank you.